session of Young India Intensivist Critical Care Webinars. It's my great honor and pleasure to welcome Dr. Manoj Goel, sir. Sir is, he has taken a few sessions earlier also. Many of you have watched, and I think the bronchoscopy one was especially popular. It's there on our YouTube channel. You can watch it if you don't know. Sir is one of the leading exponents of interventional pulmonology in our country and is a great expert in bronchoscopic techniques. And he's written a book also, Bronchoscopy in ICU, a practical guide. He is principal director and head pulmonology and critical care Fortis Hospital, Gurgaon. And he has been the principal investigator of Coventop trial published in Lancet and the LifeNox trial published in NEJM. So really wonderful work there, sir. And he has received the ICCM Chairman Award, and he's a member of several expert committees, and he is very qualified in the academic field. And he holds very nice monthly pulmonology meetings, and this has been going on for 4 years, sorry. Just like we conduct our meetings, he conducts meetings in pulmonology, which are very useful to the budding pulmonologists as well as senior pulmonologists. So with that, I'll hand it over to you. Yeah, just the topic is suppurative lung conditions. Initially, we had planned lung abscess and empyema, but then sir said this will be too much to cover in one session. So we are going to do related, something which is more related to each other, lung abscess and necrotizing pneumonia today. Empyema will cover later whenever sir has time. So with that, I hand it over to you, Manoj Goel, sir.
Thank you, Dr. Vish, for inviting me on this wonderful platform. And it has got a wonderful audience, and I'm seeing that this has been going on for many, many years. And I'm very happy that I'm on the 375th of this session. So it's been a great pleasure, honor for me to be here on this platform. And I'll try to share my knowledge and experience on the topic that you've allotted to me. So let me share my slides. The topic is suppurative lung diseases, and it's a very broad term, as a matter of fact. So when we talk of suppurative lung disease, we talk of the suppurative lung disease involving the lung parenchyma, then the pleural suppurative lung disease like empyema and loculate effusions. And when we talk about suppurative lung disease, this could be acute suppurative lung disease and chronic suppurative lung disease. Like if chronic suppurative lung disease, you have bronchiectasis, chronic lung abscess. Whereas in suppurative lung disease, we basically talk of the lung abscess and the necrotizing pneumonia. So what we are going to do today is to focus on acute suppurative lung disease, primarily the lung abscess and necrotizing pneumonia, which are not uncommon in our practice, whether it's the pulmonology practice or a critical care practice. So what we are going to talk about abscess of the lung and focus on modern therapeutic pathways, whatever latest knowledge that we have on this topic. So what is a lung abscess? Let's define it. Lung abscess is clinically defined as a cavitating lung disease, and it is usually filled with pus and necrotic material. It is typically secondary to aspiration pneumonia. And usually it's a very severe infection, but we are in sort of a clinical blind spot because we don't know exactly how to manage a patient of lung abscess or necrotizing pneumonia, because there have not been any active international guidelines on this topic. So there are zero guidelines. Like other topics, we have the guidelines which can guide us for the treatment, but here in lung abscess and necrotizing a suppurative lung disease, there are no active international guidelines. The most recent randomized antibiotic trial was published in 2008, that is 20 years ago. And therefore, the lung abscess management entirely lacks a high quality evidence, despite a very severe morbidity which is associated with this problem. So this is the baseline reality of the modern management. In 2008, we had the last published randomized clinical trial evaluating the antibiotic regimens for lung abscess. Now in 2026, so our treatment is driven mostly entirely by the retrospective cohorts and case reports. So we have got only the anecdotal reliance. And this disease has a significant morbidity and mortality. The usual hospital duration would be around 2 weeks or more. And there is a 16% risk of mortality at the 12 months. So it is a disease with severe morbidity and mortality, and leads to a lot of cost and economics to the patient and to the hospital. Now, this slide shows there's a lot of research void over 50 years as far as the publication is concerned. So if you look at the diseases like the tuberculosis, bronchiectasis, non-tubercular mycobacteria, you can see there's an exponential rise in the published papers over the last 20 years. But if you look at the lung abscess, then you find that hardly any new papers are coming, and it's basically flattening curve that you see over the years. So you can see that hardly there's interest amongst the people to publish their work on lung abscess. We don't know what the reason is. Possibly it's not the disease of the Western world. It's basically disease of our country or our subcontinent. It's basically we who have to really publish our data and share our experience to the world, as a matter of fact. But good thing is there is a historical reversal of the lung abscess mortality. So in the pre-antibiotic area, the mortality rate used to be more than 50%. And majority of time there was no other option but majority of time going for a surgical salvage in these patients, where somebody would put a drainage or maybe do some sort of a resectional surgery. But in the modern era, the mortality has come down significantly to less than 15%. This is primarily because there is a paradigm shift in better antibiotic coverage, better management of the patient, the better ICU care of these patients. And the surgical intervention has now been reduced to less than 15% of the case. So 85% of patients with lung abscess and necrotizing pneumonia are being managed medically with the antibiotics and supportive care. Now let's define the various kinds of the necrotizing lung infections, including the lung abscess, gangrene, septic emboli, and others. So there are two distinct pathways to pulmonary necrosis. One is there is a progressive scale of parenchymal damage, tissue necrosis and liquefaction. So there you would have on one edge the lung abscess, the necrotizing pneumonia, the pulmonary gangrene. So this slide or this arrow does not show the continuation of the same process. It doesn't mean that somebody would have a lung abscess first, then the necrotizing pneumonia, or then go on to pulmonary gangrene. The patient can present upfront with a pulmonary gangrene, patient can present upfront with lung abscess, patient can present with necrotizing pneumonia, and this necrotizing pneumonia can go on to lung abscess. Similarly, this necrotizing go on to develop pulmonary gangrene. Similarly, a lung abscess can go on to develop pulmonary gangrene. So this is basically the severity of the infections. So lung abscess, although these are considered to be very severe disease, but lung abscess amounts to the least severe disease as compared to the necrotizing pneumonia and pulmonary gangrene, which is the most severe form of the necrotizing lung disease. Then on the other hand, there is occlusion of the pulmonary arteries by infected material. So there is what is called a septic vasculitis of the pulmonary arteries. And this infection of the pulmonary vasculature leads to septic pulmonary emboli, because now this infected material has an access to the pulmonary arteries. So it can, disseminate through the bloodstream into the lung parenchyma and cause infection and abscess formation in multiple sites. And I'll be showing all these, various forms of the necrotizing lung diseases. So coming to lung abscess first, it's basically indolent cavity. Radiologically, you'll find that there is a large cavity which is indolent. It is localized to a single lobe, and you will find a necrotic material inside. So many times you find a fluid table there. Clinically, these cases would present with indolent course. Patient would typically experience weeks of fever and sweats before the presentation, and they would be majority of the time hemodynamically stable without much of any other organ dysfunction. And this would be a typical lung abscess that you're unaware of. There is a thick walled cavity and there is a fluid level there, which is typical of a lung abscess, and it is localized to one of the lobes of the lung. Then you got the necrotizing pneumonia, which is actually presenting as multiple micro-abscesses and is a key differentiator from the lung abscess. You got a multiple abscesses there. There's a multilobar involvement with extensive airway disease. And the other hallmark is there is a diminished parenchymal contrast enhanced. So if you do a contrast enhanced CT scan this patient, then you find there is the vascularity of the area is reduced. And this is because there is a compromised perfusion by this septic process. And these patients are generally quite sick. They would present with acute onset. They would manifest with severe clinical illness, with high inflammatory markers like increased leukocytosis, elevated CRP. Many of these patients would be having sepsis. There is a higher rate of complications like hemoptysis and complicated parapneumonic effusion. This is also intriguing. So if an abscess or if a necrotizing pneumonia is a parapneumonic effusion, this patient is likely to have a higher risk of mortality and more protracted and difficult course, as a matter of fact. So this is how a necrotizing pneumonia would look like. You find there is a consolidation, there are multiple micro-abscesses, and they are distributed bilaterally. So this is a typical example of a necrotizing pneumonia. Then we talk about the pulmonary gangrene, which is a terminal parenchymal liquefaction. Here, there is an extreme extent of necrosis of the lung parenchyma, defining more than 50% of the affected lobe. And you find there is a presence of invariably large vessel thrombosis. Either the pulmonary artery would be thrombosed, and larger vessel, there may be the whole lobar vessel or pulmonary vessel may be thrombosed, which causes necrosis, causes mycotic aneurysm that I'm going to talk about. And hallmark is a 50% affect lobe, which is involved when there is a gangrene of the lung. So this is basically clinically the final stage of necrotizing continuum driven by uncontrolled bacterial replication and exotoxins. For example, penton, valentine, leukocytin in Staph aureus and serotype 3S pneumoniae, causing massive alveolar macrophages dysfunction and killing the neutrophils. This is what a typical example would be. As you can, there is a large area of abscess, right, which is involving a large area, more than 50% of the lobe, right? And this is a very, very difficult and serious condition as a matter of fact. Then this is interesting. This we call as an outlier, where you got a septic pulmonary emboli, which occurs primarily because of the vascular occlusion. So in these patients, you find is a bilateral pulmonary abnormalities in the form of multiple abscesses, micro-abscesses, which will be seen in more than 80% of the cases. You typically will find nodal opacity with cavitation present in more than 50% of the cases. There would be a wedge-shaped opacity, which is in fact an infarct, which is a septic infarct or the infective infarct, and then there would be a feeding vessel sign which is there related to this wedge-shaped opacity corresponding to the infarct there. So here you can see there are multiple cavitating nodules, there are multiple abscesses, right? This is all due to a bloodstream infection, right? And occurs because of septic emboli from a focus. So I'll show you one of case. This is a case of IV drug abuser. He was not a HIV patient and he had a infective endocarditis of the. This is the thrombus, the infective endocarditis of the tricuspid valve, and this is a native valve. And this patient presented to us with multiple septic pulmonary emboli. As you can see, there is a cavity here. There is another nodule here, multiple nodules showing cavitation. And this patient also has a necrotizing infarct. You can see there is a wedge-shaped opacity there. And if you look at this there, you can see is the infarcted vessel, pulmonary artery, and there is a dilatation of the pulmonary artery, which we call the myocardic aneurysm. And here you can see this abscess, this infarcted area is getting cavitation, is undergoing necrotization. So it's a necrotizing septic infarct due to the occlusion of the pulmonary artery by a septic process. And this septic embolism has come from the infected, infective endocarditis of the tricuspid valve. And again, this is another example of the myocardic aneurysm. This you can see this is a dilatation of the pulmonary artery, which is blocked due to the clot, and then there is an infarct distal drain. Now, one thing that you should understand, the myocardic aneurysm does not mean it's of fungal origin. Any infective aneurysm of a vessel is called myocardic aneurysm, whether it's a bacterial or fungal. But majority of the time we find this myocardic aneurysm could be because of fungal infections also. But please do not confuse that if there is a myocardic aneurysm, it means a fungal infective aneurysm. It could be due to any kind of infection, whether it's bacterial or non-bacterial. So this patient underwent after stabilization with IV antibiotics, he was stabilized and then he underwent the tricuspid valve replacement. And this is the thrombus, which on histopathology shows, this is the thrombus, the clotted blood, and the fibrin material and other. And there you can see the colonies of the Staphylococcus aureus. And this patient also grew the aspergillus, right, which is a very rare complication as a matter of fact. In fact, we had preempted this patient could be having aspergillus infection. So we had started him on, anti-staph coverage, including the linezolid and the antifungal. Caspofungin was a choice because we thought this could be a candida bacterial infection, because the bloodstream infection due to aspergillus is quite uncommon. So we thought this could be candida, and so we covered with that the caspofungin. But with this, we changed to the voriconazole as a matter of fact. So this patient had dual infective pathology due to staph and aspergillus causing infective endocarditis and septic embolism. And of course, myocardic aneurysm and leading to infected necrotizing infarct. Now coming further, classifying the cavitary lesions, so there could be a primary cavitary pathology which arises in patients predisposed to aspiration or in otherwise healthy individuals. And there could be a secondary cause of this lung abscess, which is a complication of pre-existing local systemic condition. For example, somebody has got dendrobronchial obstruction, maybe because of bronchogenic carcinoma or a foreign body or due to HIV infection. And then this can be classified into acute and chronic depending upon the symptoms duration. So if duration is less than 4 to 6 weeks, we say it's an acute phenomena, and if symptom duration is more than 4 to 6 weeks, then we say it's a chronic infection. So what we are discussing is basically primary, secondary, acute necrotizing lung abscesses, necrotizing and suppurative lung diseases here. Now coming to the pathogenesis and pathways of infection. So the hallmark of lung abscess or necrotizing lung infection is primarily the aspiration event. Majority of time, 85% of the time, you'll find this would be the event, and this could be caused because of the endogenous systemic vulnerabilities of the patient, which may include the neurological diseases like somebody who is mentally obtunded or has got a Parkinson's disease, motor neuron disease with a respiration risk, then people with immunosuppressive conditions like HIV or on cytotoxic drugs, then people who have already a structural lung disease like COPD and bronchiectasis, where the lung parenchyma is already colonized with the infective organisms and the bacteria. And then there could be exogenous behavioral risks, like somebody who is using sedatives, has been alcoholic, and somebody's got a poor dental health. So all these patients lead to increased risk of especially the anaerobic infection. And majority of time you find a combination of both endogenous and systemic vascular vulnerabilities and the exogenous behavioral risks, which lead to the aspirational risk and then moving on to develop the necrotizing lung infection. So this would be the pathogenesis cascade. So there would be a mechanical trigger, like patient would be having impaired consciousness, which may be because of alcoholism, dysphagia, or maybe post-operative patient majority. Many times we see these patients aspirating, and this leads to the compromise the cough reflex. That causes microaspiration, and aspiration would be in the form of the aspiration of the oropharyngeal flora, and this would be exacerbated by poor dental hygiene and gingival diseases. And if this material is infected, then you have got quite a bit of anaerobic infection, which is gone inside the lungs. And then there is a polymicrobial proliferation. The bacteria multiply in the alveoli. They release toxins and local inflammation is triggered, which leads to massive neutrophilic response. And then next step would be tissue hypoxia. This inflammation, bacterial coagulase, protease, enzyme lead to small vessel obliterative vasculitis and thrombosis. And then this leads to parenchymal necrosis. Liquefied tissue then communicates with the bronchial tree, causing classical expectoration of the foul-smelling sputum, leaving a cavity behind. So ultimately, there will be liquefaction and cavitation within the lung parenchyma. Coming to the special anatomy of the clinical presentation, majority of time, the 30 to 40% of time, the abscess is located in the right lower lobe or the upper lobes. If you talk about the upper lobe, then these are the basal segment of the upper lobes which are affected. And this is because the abscesses preferentially form in these dependent area because gravity declares the path of least resistance for the aspirated infected material. Now, if you find the abscesses in the non-dependent areas, like in the upper lobes, right, the anterior segment, right, or the apical segment, then you think of etiologies which are non-aspirational, like it would be because of mycobacterium tuberculosis, maybe nocardia infection, or maybe aspergillus or something else. The median size of the cavity or the lung abscess would be around 5 centimeter, and 71% of the patients with necrotizing lung disease or suppurative lung disease would present with single lung abscess. As far as the patient profile is concerned, the mean age group is 65, so elderly population is most vulnerable. That too amongst the male, which is 63%. And there is a strong association with smoking. These patients, as 75% of these patients would be current or the previous smokers. The prominent presenting symptoms would be cough, which would be there in 80% of the patients. Many times these patients would present with malaise, loss of appetite, not feeling well. In around 60% of patients, there could be history of fever. And hemoptysis may be there in some cases, but is rare. Occasionally, it's linked to the pulmonary artery aneurysms. Now, this was the anatomy of the cavitary disease. So what you find, there is a fibrotic wall around the cavity, which is thickened. This fibrotic tissue surrounds the lesion, and the clinical implication is that it restricts blood flow, severely impeding the antibiotic proliferation into the core. So it forms a sort of a boundary wall, right? A fence, so that it does not allow the entry of the antimicrobials into the infected area, right? So this is the biggest problem. Then you got this necrotic core in the middle, in the center, which is consisting of liquefied pulmonary debris and dead neutrophils. The clinical implication is a hostile hypoxic environment where indolent anaerobes survive. So the anaerobes, the bacteria, they got a good material, good medium to flourish, and there is no blood supply, and they got a necrotic material there to thrive and flourish and multiply. And then ultimately there is a communicating bronchus, the side where the abscess has eroded into the airway, and the clinical implication is it causes the radiographic air fluid level and the sudden clinical expectation of putrid foul testing sputum. Now, coming to the microbiological spectrum of the necrosis or the lung abscesses, this could be because of anaerobic infection or the aerobes. Anaerobic infection generally would include the bacteroids and fusobacterium, and they would generally have an indolent course. Whereas the aerobes like Streptococcus pneumoniae, Klebsiella, Pseudomonas, and Staphylococcus aureus or MRSA, they cause aggressive acute episode of the necrotizing infection, lung abscess, and necrotizing pneumonia. And these patients will be very, very sick, as a matter of fact. And there is a mixed flora where you got a synergistic infection of both anaerobes and aerobes. So depending on the microorganism, the course of the lung abscess or the necrotizing pneumonia is decided. So the big three pathogens which cause severe infection would be Streptococcus pneumoniae, especially the serotype 3, the Staphylococcus aureus, which is PVL, that is Pentam Valentine leukocytin, I'll stress upon it, and then the Klebsiella pneumoniae. And these would be more dangerous in patients who have got host vulnerabilities, like those who have influenza co-infection recently, patients with poor risk like having leukopenia or primary biological features with death, and social demographic features like those who got a history of smoking, alcohol use, diabetics, IV drug use. So these are the vulnerable population, and there are three big pathogens which cause devastating illness or lung destruction due to the suppurative process. Now coming to pathogenesis of necrotizing pneumonia. So what is the standard defense protocol that we see? So there is, effective clearance of micro-aspirated respiratory pathogens, which relies on the coordinated action of the airway epithelium, alveolar macrophages, and recruited neutrophils. This is what happens. So as the microbes come in contact with airway epithelium, they interact with the, this airway epithelium interacts with the bacteria through the TLR2 activation, which causes a controlled release of local cytokines and chemokines, which lead to the migration of neutrophils, and they are recruited to the alveolar space. And then these neutrophils sort of phagocytize these microorganisms. They kill these microorganisms and then digest them. So this would be a standard defense protocol where the inflammatory cascade between the airway epithelium and bacteria is controlled, which which recruits the neutrophils, and then these neutrophils beautifully, without causing much of inflammation, kill these bacteria and phagocytize them and digest them, and no injury to the neutrophil occurs and no injury to the lung tissue occurs. But when this standard timeline is hijacked, then you've got this devastating illness. The exotoxins, when they're present, when they're released in abundance by these organisms, the microorganisms, then they sort of hijack this timeline of the standard protective mechanism, and it leads to the neutrophil lysis. So the neutrophil which are there for the defense are destroyed by this exotoxin release. There's a macrophage dysfunction, and this also leads to tissue necrosis and causes destruction in the lung parenchyma. And the two most important invaders, the armored invaders, are serotype 3S pneumonia, and this serotype, and the other one is Staphylococcus aureus. The serotype 3S pneumonia has 15 times higher exponential necrotizing risk as compared to the standard pneumococcal serotypes. And the other one is the Staphylococcus aureus, which releases the Pentam Valentine leukocytin, PVL exotoxin, which drives the vast majority of Staphylococcus necrotizing pneumonia. And I'll explain all this. So what serotype 3 pneumococcus does, it forms a rapid accumulation of capsular polysaccharide, which physically blocks the alveolar macrophages from performing the phagocytosis. So this rapid accumulation of capsular polysaccharide by the serotype 3 pneumococcus actually repels these macrophages from the neutrophil, and therefore, the phagocytosis is impaired. And on the other hand, the PVL3 toxin, which fortunately occurs in less than 50% cases of MRSA infection, this PVL causes lytic pores in the neutrophil membrane. So it sort of invades into the neutrophil membranes, and this causes release of chemotactic factors mediating massive tissue necrosis and cell destruction. So actually, the PVL forces the uncontrolled release of potent chemotactic factors and internal antimicrobial proteins directly into the fragile lung parenchyma, which cause severe lung dysfunction. So actually, the PVL turns these neutrophils into bombs, which release these chemotactic factors and perpetuate the necrosis and the lung destruction. So there is a dual threat of pathogenesis. There is evasion and exotoxin by the serotype 3. So by the capsular polysaccharide release, it causes a physical blockade of the macrophages, and by destroying the neutrophils, it releases various kind of destructive tissue toxins like pneumolysine, hemolysine, leukocytin, which cause further destruction in the lung parenchyma. So you got a PVL-induced neutrophil lysis, then you got a serotype 3 led toxin wave, which causes severe uncontrolled inflammation. There's a thrombus formation in the pulmonary vasculature. This leads to severe perfusion restriction, ischemia of the lung parenchyma, and then it causes parenchymal liquefaction and pulmonary gangrene. So this would be the clinical endpoint. You'll find multiple micro-abscesses, or there could be large abscess there. Then there could be a progression to pulmonary gangrene, and then there is a ischemia of the area, which leads to compromised perfusion and further destruction. So this is the clinical endpoint of the tissue destruction of this devastating pathogenic process. Now coming to the clinical presentation, if we compare with the standard community-acquired pneumonia, there is a rapid decline in the necrotizing pneumonia. So if you look at the standard community pneumonia, the onset paradigm would be this, there would be a little indolent or standard progression. Of course, even the CAP can present with very severe disease, and many of these patients can progress very rapidly to ARDS. But in mota, if we were to compare between this community-acquired pneumonia and necrotizing pneumonia, then you'll find that the onset of the standard pneumonia would be indolent, there would be standard progression, whereas in necrotizing pneumonia, there is a rapid progression directly into the severe sepsis. The complication like parenchymal fusion empyema occurs only 6% of cases of community-acquired pneumonia, whereas it is around 47% patients who have got the necrotizing pneumonia. Hemoptysis is 9% in CAP, whereas hemoptysis in necrotizing pneumonia would be as high as 16%. And the biomarkers would be significantly raised in necrotizing pneumonia, that you may have increased leukocytosis, ESR, and CRP and procalcitonin more as compared to the standard CAP. So clinically, the patient would present with, intermittent fever, severe prostration, weight loss, and night sweats. And many times the course is lasting for more than 2 weeks. The patient would be producing, productive cough. And the expectation characteristically would be putrid, foul smelling, especially if there's an anaerobic infection. And this would occur only when the lung abscess formation has occurred and cavitation has occurred. And sometimes there could be hemoptysis. On physical examination, you may find coarse bronchi or absent breath sound in the affected segment. And in chronic cases, you may find digital clubbing, which is a hallmark of the chronic lung abscess or chronic necrotizing pneumonia. Coming to the diagnostic funnel, so first you will take a clinical history of this patient. They would present with fever, weight loss of more than 2 weeks. They will be, if you do a local examination, you find their dentition is in poor hygiene. First step is that you send a sputum culture in these patients. Then invariably you would do a chest X-ray or CT scan, which would identify there is an infection or necrosis going on in the lungs. And then you may have to perform bronchoscopy in selected patients, which is a very important diagnostic tool of choice to identify the type of microorganism and also to exclude underlying endobronchial pathologies like malignancies or foreign bodies, which is causing obstruction drainage and maybe the cause of lung abscess. And we have found over the years that in cases of chronic lung infection, those presenting with chronic pneumonia or recurrent pneumonia, there is a foreign body underlying there, or there is a tumor or maybe a carcinoma which is sitting there and is the cause of recurrent pneumonia, recurrent lung abscesses. So bronchoscopy does play a very important role. The radiology is the hallmark in the diagnosis of the lung abscesses. The first would be a plain X-ray where you may find a consolidation with classic thick wall cavity containing air fluid level in a dependent segment. But the CT scan, especially the contrast CT scan, is the investigation of choice, where you find typical features of the lung abscess, the necrotizing pneumonia, and its complications, like associated pneumonias and others. So chest X-ray would be the preliminary infection, but it has a limited value, especially in the early stages where these lung abscesses may be missed out. Remember, the chest X-ray shows only 60 to 70% lung parenchyma. It doesn't show the full lung parenchyma. But the diagnostic gold standard remains the contrast CT scan, where you should give a contrast enhanced, we should do a contrast enhanced computer tomography of the lung, which is a definitely gold standard for the morphological diagnosis of lung abscess and necrotizing pneumonia. As here you can see, you can find this lung abscess, you can find other features like there is a encysted empyema, there is a collapse of the lung, and you can see if you decrease perfusion. It's a contrast, but there is a decreased perfusion of the area, which is again a hallmark of a lung abscess or necrotizing pneumonia. So what you see is there will be micro-abscesses. There may be a bulging fissure sign because severe and enormous exudation due to the necrosis and inflammation. And there's a diminished enhancement because of the lack of the parenchymal contrast uptake, indicating compromised perfusion and tissue death. So CT remains the definitive for localizing the lesion. It's crucial for measuring cavity size to guide drainage decisions. So suppose the cavity size is large, especially if it's more than 3 centimeters, then start thinking of draining these cavities, these lung abscesses, and I'll talk about this later. And this can also identify the complicated pulmonary artery aneurysm, which I have shown already and I'll show you further. Now, ultrasound is an emerging point of care, especially in patients who are ICU. It's a bedside procedure where it can be done safely, especially in patients who cannot be transported for the CT scan. And it can detect lesions which are missed by standard X-ray with zero radiation burden. And therefore, it enables early detection of abscesses hidden within the consultant parenchyma. So, ultrasound is a very important emerging point of care tool, especially in intensive care unit, where you can diagnose the lung abscess and necrotizing pneumonia early. Coming to the features of necrotizing pneumonia, you'll find this is these areas of consolidation which may be there in bilateral and both the lungs. There will be presence of micro-abscesses. There is again, you'll find areas of low attenuation, increased enhancement conforming to the inadequate perfusion. And there can be multi-lobar involvement, especially the right middle lobe and lower lobe. So, the multiple lobes may be involved, which may be on the sink, one side of the lung or maybe the other side, or means it can be bilateral involvement. This is the septic pulmonary emboli. The typical features would be bilateral nodular opacity, which you'll find in around 80% of the cases. You may find cavitation, which is seen in more than 50% of the cases. And then you've got this infarcted area with a feeding vessel sign. And this is something that I've already discussed. Coming to the further investigation, you want to assess the microbiological status of these patients. The sputum culture will be the traditional baseline culture. So non-invasive standard filtering doesn't cost much. But the problem is a high false negative rate, approximately 50% of cases. And there is also a massive risk of oral flora contamination. So there is a good limitation. There is a great limitation of the regular traditional sputum culture. Now, to solve this culture yield deficit, the emerging technology is the NGS, that is next generation sequencing, which can identify the exact pathogens despite various antibiotic use. It can differentiate true infection from more colonization and directly informs the antimicrobial stewardship. So you can be more calculated in your antibiotic coverage rather giving too much of a broad spectrum antibiotic. The antibiotic coverage can be directed and therefore it can help in antimicrobial stewardship as well. So NSG confirms the lung abscess pathogens originating directly from the oral cavity. It can differentiate the lung abscess pathogens different from the oral cavity, or can rule out the possible contamination. And it identifies the pathogens even false negative radiation culture. As you can see, the 50% there is a culture rate failure. And it helps in antimicrobial stewardship and ends the broad spectrum guesswork. So you can give a targeted pathogen, a targeted pathogen identification and give a targeted antimicrobial therapy in these patients. So coming to the diagnostic pipeline and the role of the bronchoscopy. So first you would do a non-invasive investigation like obtain extraspectral sputum, blood cultures prior to initiating the antibiotics. And then you would assess for clinical profile. If there is an anaerobic infection likely based on the history, like somebody who's got who is an altered sensorium, myasthenia gravis, or has increased risk of aspiration, alcoholic, then you can start with the empirical treatment with the anaerobic coverage. But if there is no anaerobic infection likely, then you may go for atypical pathogens like aerobic fungal infection and mycobacterial. And in these group of patients, fibrous bronchoscopy may be indicated, which can rule out the underlying neoplasm or cancer or a foreign body and detect unusual pathogens like aspergillus. Important thing is that you should avoid doing a therapeutic bronchoscopy in these patients, which can cause inadvertent release of large volume of pleural material into the other lung segment, risking acute respiratory distress syndrome. So there is a talk of the bronchoscopic drainage of the lung abscess, which I think should be avoided as far as possible. You got other measures to drain the abscess or aspirate the abscess. So bronchoscopic aspiration or therapeutic bronchoscopic aspiration of lung abscess should be avoided, which can be catastrophic for the patient. You can do a bronchoscopy from the diagnostic point of view to rule out any underlying endobronchial occlusion, obstruction, and for the microbiological investigations. Now, for example, this patient came to us from other hospital. He was on antibiotics for 2 weeks, not responding, very toxic. And you can see there's a necrotizing pneumonia involving right upper lobe, dense consolidation. And we did a bronchoscopy in this patient and we found there is a thick mucus plug which is there, right? And we use the cryo to extract this mucus plug. And after that, the patient responded very well to the treatment. So this is the X-ray before the treatment, and this is the treatment. This is the X-ray after 2 weeks after treatment, after we had removed that mucus plug. And after that, the patient responded very well to the treatment. So diagnostic precision drives aggressive medical management. So we must use tailored antimicrobials. the rule is that we have to use extended duration of antimicrobials for 2 to 4 weeks. In fact, in some cases, we can go up to 6 weeks or more. We must try and target the core pathogens, anaerobes, the toxin-producing strains, for example, MRSA with linezolid. Source control becomes very important. So if there is a large abscess, that's better that we drain this abscess by percutaneous mean, right? Majority of time. There has to be a surgical restraint now. So we should continue with antibiotics and see how the patient is responding. And surgery must be reserved strictly for failed medical therapy, persistent hemoptysis, or extensive gangrene due to high operativity. So primarily, the the current strategy is to treat these patients with antimicrobial therapy with source control by using percutaneous drainage. And then with this strategy, 85 to 95% of the uncomplicated cases can be treated very effectively with this dangerous, aggressive, necrotizing lung diseases. So this would be the antibiotic regimen, which used to be the previous regimen, say about maybe 20 years ago, where the gold standard would be clindamycin, especially when you're suspecting anaerobes. Then for a broader coverage, they were used to use the ampicillin-sulbactam combination, and moxifloxacin was the conventional alternative. But recently, we generally go by, because the microbial invasion, the types of microorganisms have have changed over a period of time. We are seeing more of resistant, even community-acquired infections. So current empirical treatment algorithm would be that if you're suspecting community-acquired pneumonia, then you can start with core regimen of ampicillin-sulbactam. Remember, the dose has to be high, that is 3 gram IV 6 hourly. You can combine a macrolide azithromycin. And if you're suspecting there's a hospital-acquired infection, then you can use a piperacillin tazobactam or even a carbapenem with the dose of meropenem of 1 gram of 8 hourly to cover pseudomonas. Generally, what we do, we give a combination of, in our patient, a combination of clindamycin and pip-tazo, and a very severe patient we switch to linezolid and a combination of the carbapenem in those cases. The MRSA would be indicated if there is a risk of MRSA infection, like the patient has a history of flu co-infection, has been a diet drug abuser, has a prior history of MRSA. Then those patients, it's better to start upfront with the MRSA coverage as well. And again, there is a discussion whether to use linezolid or vancomycin. I'll talk about this. So there is a toxin dilemma whether to use a lytic anti-staph coverage or non-lytic anti-staph coverage. So with vancomycin, is the mechanism of the action is that it lyses the bacterial cell wall. And already we see that in these patients, there is a lot of lysis of the neutrophils. So theoretically, there could be a trigger for massive release of inflammatory components and pre-formed toxin to the lung parenchyma if you use vancomycin, because it is lytic mode of action. Whereas linezolid is a non-lytic antibiotic. It inhibits the bacterial protein synthesis and reproduction without lysing the bacteria. So therefore, it can suppress the production of the exotoxins like PVL and minimizing the extreme inflammatory response. So we don't have a head-to-head comparison with vancomycin linezolid, but theoretically, looking at the profile of these patients, it's better to prefer linezolid as a non-lytic antibiotic over a vancomycin, which is a lytic antibiotic, which can in fact cause pro-inflammatory cytokine release, and intracellular toxin cause in fact more damage to the patient. Now, how do we monitor this patient? So we have started antibiotics. So what we expect that in 3 to 4 days time, there would be initial clinical improvement. The fever would begin to break, as a matter of fact. By 7 to 10 days, you'll find that the patient has become afebrile, what is expected. And then the patient may have to be continued for antibiotic for 3 to 6 weeks till there is a radiological resolution. So duration rule would be the IV antibiotic has to be given until clinical response occurs, and then you can transition to the oral when you are quite confident now the infection has come under control significantly, and treat continuously until there is a complete radiological resolution, or only a small stable thin wall cavity of less than 2 centimeters remains to prevent relapse. So it's better to overdo with antibiotics in these patients. As far as the duration is concerned, you may continue for 3 weeks, 6 weeks. You may have to give IV antibiotics maybe 4 weeks or longer, depending on the condition of the patient. Now, assessing the response, the 10-day failure mark is the important landmark, right? If there is a persistent fever which is beyond 7 to 10 days, it means there is a possibly therapeutic failure, and this mandates immediate re-evaluation. So here we go for a diagnostic checklist for the failure. There could be an anatomical factor leading to this failure, as the size of the cavity may be more than 6 centimeters, which requires significantly prolonged therapy. Then there could be obstructive airway disease in the form of an obstruction of the airway, with a foreign body or neoplasm which is blocking the natural drainage, and then we have to relieve that. And if the microbiological pattern is resistant one, like, or if something else like mycobacterial or fungal infection or aspergillus infection, which can coexist in these patients. As a matter of fact, recently we had a patient who had a coexisting the necrotizing pneumonia with tuberculosis, and we had a very tough time with that girl. And if there's a misdiagnosis, it could be a non-bacterial cavity disease like lung infarction, vasculitis. The Wagner's granulomatous may present with multiple lung abscesses, and there could be an emphysema bulla, which may be there, may be confused, and a lung abscess. So important thing is, if there is a treatment failure, impending treatment failure, or there's a large abscess, then it has to be drained. One way would be to do spontaneous drainage by using a postural drainage, which is little controversial and should actually be avoided because this can cause spillage of the infected material to the other healthy lung. So postural drainage, unlike bronchiectasis, must be avoided in cases of in the lung abscesses. But percutaneous drainage can be indicated if there's a complicated abscess with ongoing sepsis, there's a progressive enlargement which is risking the rupture of the abscess, and failure to wean the patient from the ventilator in patients who are too critical for thoracic surgery. It has been found to be quite safe. The complication rates that we expect, that there could be a formation of the empyema, or there could be a bronchoperfusion, has been actually very rare. So you can safely perform a percutaneous drainage, which can be done under ultrasound guidance or under CT guided by interventional radiologist, and this can help the patient. Like this patient of ours had a large abscess. It was a necrotic lung, as a matter of fact. It was a gangrene. And here we put this percutaneous drainage safely under local anesthesia, and this was the drain, and then the patient after that did very, very well. So if you look at the interventional window, the transthoracic drainage performed within 1 week of diagnosis leads to a much better outcome, as a matter of fact, right? And the patient selection would be if there is abscess size more than 3 centimeter or mean 6 centimeter, and the complication rate that you would see would be less than 10%. So you've got an abscess which is more than 3 centimeters. It's better to be proactive while you've started the antimicrobial therapy, is to go ahead and do an early percutaneous drainage. As you can see, the median hospital stay was 28.6 days when the early drainage was done, as compared to 40 days when the late PCD was done, that is, the percutaneous drainage was done. And similarly, the positive culture outcome was better with the early percutaneous drainage as compared to the late percutaneous drainage. So early percutaneous drainage in a patient who is vulnerable, especially with abscess size of more than 3 centimeter, should be considered along with the antimicrobial therapy in these seriously ill patients. Now coming to the surgical tipping point. So if you look at the risk of surgical resection, the mortality is around 15.4%, whereas the mortality with the medical management is 8%. Definitely the surgical resection has a higher mortality, as a matter of fact, as compared to the aggressive medical management. So when would you consider this surgical intervention? When there is aggressive medical management which fails. This could be because of parenchymal complication, or could be because of pleural complication. Parenchymal complication would include absolute medical failure, or there is a refractory hemoptysis, or there is a more than 50% pulmonary gangrene, or there is a pleural complication like stage 2 acute empyema, where there is a fibrinous or complicated empyema, or if there is an organized stage 3 organized peel which is there, so they got a thickened pleura which is which has to be stripped off, and decortication has to be done. So in those cases surgery would be indicated. So surgery is used as only a last resort. It's required in less than 15% of the cases, and lobectomy is the gold standard. Pneumonectomy is extremely rare, reserved for multiple abscess or pulmonary gangrene. You want to do a conservative surgery, but you don't want to do a segmentectomy in these patients. So either a lobectomy, which would be the preferred one, or in exceptional case, a pneumonectomy, but avoid doing segmentectomy in these patients. So what you see that cavity in these patients is actually destroyed beyond the reach of systemic antibiotics, necessitating the physical removal. And as you can see here, this is an operated lung specimen with gangrene completing the lung abscess. So all the pus and muck is seen inside this lung abscess, and this is the wall of the lung abscess. And you can imagine no antimicrobial is going to reach there and going to be effective. So this is one of patients who had a right upper lobe large abscess, and he underwent lobectomy. This is the lobectomy piece that you can see. And another case of necrotizing pneumonia, a patient with uncontrolled diabetes who presented with recurrent cough, fever, and mild hemoptysis for 1 month. And here you can see there is an abscess here, or it is a necrotizing pneumonia, you may call whatever it is. But intriguing point is you can see this pulmonary artery, left pulmonary artery, sitting inside the abscess. right, which is dilated. And this is the another view. Here you can see this is the mycotic aneurysm. And here is the infarct which is there. And you find these micro-abscesses there. Now, this patient was quite stable. He was having only mild hemoptysis, but we did not wait in this patient because this patient is sitting on a volcano, a, a, a dilated vessel sitting in a necrotic abscess, necrotic area, right? Is a dangerous patient, is a dangerous condition. And if you try and do a bronchoscopy in this patient, I mean, this could be catastrophic. This ruptures, you won't be able to handle it. And therefore, this patient was upfront taken as an emergency case for lobectomy. And this is the resected left lower lobe. And here you can see is the vessel of the which was removed and resected. And this patient had a combination of mucormycosis and aspergillosis. You can see these ribbons of the mucor, and even the aneurysm wall was invaded with the mucor and the aspergillus. So, this was a very aggressive presentation of the aspergillus infection. Now I talk about these some of the mimics of the lung abscess, which mimic it, but they are not the lung abscess. There we have to be careful, especially squamous cell carcinoma, lung carcinoma. Here you can see this, it's absolutely mimicking like an abscess. It will be very difficult to differentiate whether it's an abscess or a squamous cell carcinoma. Here the material that you see is actually a liquefaction necrosis rather than infective necrosis. So history plays a very important role. Majority of the time these patients would present with a mild hemoptysis. They won't have any, malaise or any fever. And then you find that this shadow is there. But majority of time you may have to do a biopsy to confirm the diagnosis. But yes, I understand, it may be difficult to differentiate a carcinoma from a lung abscess, especially if the region like this. This is a chronic tubercular cavity. It is looking like abscess, but it's an inert cavity. And you can see it's lying in the upper lobe. There is a smaller left hemithorax, and there is a surrounding fibrosis and bronchiectasis. So this is not an abscess. This is a tubercular cavity. This is air crescent sign, which is a resolution phase of a nodule of an aspergillus infection. Right? This occurs in the resolution phase. So this is not an abscess. Then this is the reverse halo sign, where you can see it looks like a necrotizing pneumonia, but you don't find any lung destruction here. In fact, there is a ground glassing which is surrounded by a consolidation. This is called a reverse halo sign, which is seen in cryptogenic organizing pneumonia. And these patients, rather than requiring antibiotic, would require heavy dose of steroids. So that's why you have to be careful. That this is a patient with necrotizing bronchiectasis. What you can see here is we may say that these are the cavitating mass lesions, bilateral cavitating mass lesions. But as a matter of fact, they were bronchiectasis. So we did a bronchoscopy in this patient. And as we pass the bronchoscope, you can see the left upper lobe is all destroyed, right? And you can see it's all eaten up. Okay, there's a lot of debris. Of course, there is surrounding lung destruction, but it's primarily a bronchiectasis, necrotizing bronchiectasis. There's a lot of debris and slough there. And the culture showed these cotton wool colonies of the mucor. So this was not an abscess, but it was a necrotizing bronchiectasis. And this is a very recent case we had. And so patient upon to see me in the surgical ICU to see. And I saw, oh, this is an abscess. But in fact, this was a pulled up stomach. This patient was a case of CA stomach, in which the gastric pull-up surgery was done. So it is not an abscess, it is a pulled up stomach, which is causing compression of the adjacent lung parenchyma. So you have to be mindful of what you are seeing on the CT scan or the imaging, and the history becomes very, very important. So these are some of the mimics. We are not the abscesses, but they are something else. Now coming to my final slides in conclusion. So the final takeaway is the era of high lung abscess mortality is over. With prompt microbiological identification and targeted prolonged antibiotic therapy of 3 to 6 weeks, even longer, over 85% of the cases can be treated successfully with medical means. Success relies on the discipline to wait for medical resolution, but we should not wait too long. Maybe 10 days is a good enough time, cutoff time, where we start thinking as to what is missing there, while maintaining the vigilance to recognize the precise moment surgical salvage is required. So after 10 days, you start thinking of surgical salvage, but still you have to be very careful. So these are the 3 pillars of a success story. Pillar 1 is there is a high suspicion. You have to high suspicion of lung abscess. So don't confuse with a bronchogenic carcinoma or lung carcinoma. Suspect necrotizing pathogen patient presenting with rapid onset sepsis, leukopenia, or pneumonia secondary to an influenza co-infection. Pillar 2 is definite imaging. Do not just rely on chest X-ray. Get a contrast and enhanced CT scan in this patient to identify micro-abscesses and compromised parenchymal perfusion, and also the complications like parapneumonic effusion, and empyema, and choose for aggressive medical treatment over the surgical treatment. Treat extensively, extendedly, longer period for 2 to 4 weeks with broad spectrum antibiotics, preferring the non-lytic MRSA coverage with lenozil rather than the ticoplanin. Reserve high mortality surgical section strictly for absolute medical failure or gangrene. But important thing is we have to bridge the guideline void. Currently, our knowledge is based on these fragile pillars, right? You got anecdotal case reports, retrospective cohorts, and an antibiotic trial which was done around 20 years ago. So this is not going to sustain. What we need is a prospective randomized trials, antimicrobial steward data, and evidence-based international guidelines. With this, I thank you all for your patient listening, and I'm ready to be there to answer any of your questions. Thank you very much.
Thank you, Dr. Manoj Goel, sir. So, I request the audience if they have any questions, please put up the questions. So, I'll just put up a few points for discussion, sir, would be of interest to everybody. No questions so far from the audience. So, you very nicely showed a lot of slides, colorful slides, images, and even some cases. So, first is about the pathogenesis. You explained very nicely about the separation and all that. What about the fibrosis? Do we understand how the fibrosis forms in the lung abscess cavities? Like that is one of the problems, right? Because it has a thick fibrotic cavity if the drugs don't penetrate, the antibiotics.
So this is what happens. I mean, simultaneously with the inflammation, there's a fibroproliferative stage that also starts. Body tends to heal, and the healing would be by the fibrosis. So the inflammation is there, and the body is trying to, heal it by advanced, this recruitment of these epithelial, the fibrotic cells, what you call cells, and that they sort of form the wall along it, around it. So this is a natural way body responds to for the defense if there is a infection like this.
Right, sir. So then the case of tricuspid valve endocarditis, where he got a dual microbiological diagnosis and he was not HIV. So did you find any immunocompromised state or anything in the history of the examination, or did you evaluate it for anything?
So this patient was a young guy, 22-year-old, and he was using these IV cocaine and other things.
Oh, okay.
But he was not HIV positive. He was not HIV positive, and he came to us with a 2 weeks history of high-grade fever and respiratory distress, hypoxic, and he was very sick as a matter of fact. So we gave him, a course of antibiotics for about 10 days because he had to be stabilized before that. The bacterial load and the microbial load has to be reduced before the patient undergoes the knife. Of course, from the day one, we were very clear that this patient would require a tricuspid valve replacement. So before we replace the valves, we should try and get the area, sterile as far as possible. So the dictum is that you treat them with a course of antibiotic for 7 to 10 days and then go for a valve replacement as early as possible. And this is what was done in this patient, and this patient has been doing very well with a combination of voriconazole and still lenozil going on in this patient.
Excellent. So it was IV drug abuse. That was the risk factor, huh?
Yes, this was a risk factor. It's a native tricuspid valve, as a
All right.
matter of fact.
IV drug
Yeah.
abuse. Okay, sir. So then about the role for anaerobic cultures. Is there any role, because the primary lung abscess is predominantly anaerobic etiology? Is there any role for anaerobic cultures?
I think history plays a very important role, and we must cover for the anaerobic coverage. And the kind of antibiotics that we have, that the carbapenems and the peptizo combination, they do have a good anaerobic coverage. But initially, we would like to cover them with clindamycin and peptizo in majority of our cases. The anaerobic cultures are not very common in our practice. Majority of us are not doing anaerobic culture. I think very few hospitals are doing it. This has not developed in our practice. As a matter of fact, something that we need to do. But I think biofire coming up is a very great help, as a matter of fact. So now we try to do a bronchoscopy in these patients as early as possible and send these patients the cultures, the biofire, right? That can give us an upfront clue. I don't mean that they can give us 100% clue, but they can give us a good clue as to what kind of organism it is. If it matches with a clinical, suspicion, then we can treat them with the specific antimicrobial therapy.
Right, sir. So just a final point, sir, about the therapy part. Now, we are supposed to give antibiotics for a longer duration in these patients. And we've also had some patients, and there's a tendency to persist with the antibiotics and kind of hope for resolution and not intervene. But you also showed that if you do percutaneous drainage, you get better results, faster results. So how do you balance this?
Yeah. So if my abscess lasts says more than 3 centimeter, it is peripheral, I would rather go ahead with the percutaneous drainage upfront and start the antibiotic. And this also gives me a very good culture, opportunity to culture this material, which is directly from there. So I would like to do that. The Perkins drainage, I'm quite fond of it, and especially it is very easy to do and it has hardly any complication rate. Even the sickest of patient who may be on ventilator, who may be in associated ARDS, hypoxic condition, you can perform bedside under the ultrasound. So there is no harm done. So we would like to do it, and especially in some patients where I've given a 10 days of antimicrobial therapy and is not responding, then even borderline cases we may like to do it as a matter of fact, if it is feasible and practically possible, where we may not put a permanent drainage there, but at least we try and aspirate percutaneously as much pus as it is possible. So that is what we try to do. But so it can be individualized practice depending on the condition of the patient. But a large abscess is 6 centimeter or 5 centimeter is better to go upfront with the percutaneous drainage with antibiotics, get the material cultured, right, and then be more give a more targeted therapy and get a good outcome. Surgery would be in very select cases. I've shown you a couple of cases. In fact, the patient was not very sick, but this patient was at imminent risk of massive hemoptysis, massive bleeding, right. In fact, I had to arrange the surgery in this patient very, very quickly. The moment patient landed up in my OPD, and then I recognized the sepsis. So I alarmed everyone that this patient has to be operated immediately, and this is how it was done. So again, patient may not be very sick, but they were seeing there is imminent danger. Of course, surgery may not be indicated in majority cases, but there is imminent danger where surgery is the salvage. They should go ahead and do it.
Okay, sir, great. So, one of the things you did mention and showed was mycotic aneurysm in the lung abscesses. So, do you think this is common, sir? Because this is not really reported so much in literature, I think. You showed a lot of
So
mycotic
literature is
aneurysm.
blind. I mean, literature is blind, and that's why there has to be good communication with radiologists. And fortunately, we've got a very good radiologist with us, and who understands what we want, and I also understand him, and he's very astute. So it all depends on how much you are going to communicate with them, and as you communicate, you find that there are new things. So majority of these cases I have got, after communicating with my radiologist. Otherwise, if I have not communicated with them, I would not have been able to present these wonderful cases to you.
Uh,
So we do see these cases, and if you look at the hallmark is the septic vasculitis. So if there is a large abscess is there has to be a mycotic aneurysm there somewhere sitting there, or especially necrotizing pneumonia that has to be there. One has to look out for it. For this, I think it's better to do a CTPA. CT pulmonary, without doing a CT pulmonary angiography, you cannot identify mycotic aneurysm. So I think there should be a low threshold of doing CTPA in these patients, so that you can actually see what kind of, these patients, infection these patients had. And there's a large mycotic aneurysm, possibly these patients would become a candidate for surgery as well.
Right, sir. Thank you, sir. Thank you so much. It was really nice, wonderful, wonderful for the audience, and we are a good audience. And it will be put up on the channel after a few weeks, so other people can watch who have not been able to watch. Your bronchoscopy lecture is very nicely being viewed. Wonderful viewership, and I think people who want to review it can also review it. Thank you. I thank the audience also. Thank you, sir.
Thank you very much. Thank you, Dr. Tapesh. Thank you for having me here. Thank you. God bless. Thank you.
God bless, sir.